Hi there, and welcome to Speaking Frankly with me, Professor Franklin Joseph. I'm very pleased to have with me today a very close colleague and friend, a renowned consultant oncoplastic-breast surgeon. And what that is and what that means is that Mr Mysore Chandrashekar is a cancer surgeon who deals with and helps people get over breast cancer. Breast cancer, as we all know, is one of those cancers that has become a topic that we are all familiar with. And partly that's because the numbers are going up, because we are more aware and we're able to identify. And partly that's because we can do so much more about breast cancer nowadays. And I'm really privileged to have, I'm going to call him Chandra, because that's what everybody calls him. Chandra with me today. And I'll let Chandra say a few words about himself to start, and then we'll get into the discussion. Chandra, over to you.
Thank you, Frank, for the kind introduction. And it's been a pleasure to take part in this and contribute for your fantastic series of Speaking Frankly. Frank says, I'm Mr Chandrashekar, one of the Consultant Oncoplastic Surgeon. I work mainly at the Royal Liverpool University Hospital, but I also have practicing privileges at Spire, Murrayfield and Spire, Liverpool. My background is a general surgical training, followed by breast-specific training, and I was the first oncoplastic trained consultant in this country, one of the first consultants. So oncoplastic surgery is basically, as the word implies, two parts to it. There's oncology and the plastic surgery aspects to it. So it's all about treating breast cancer with surgical procedures, but incorporating plastic surgical principles. So you not only cure the patient, remove the cancer, but at the same time restore the aesthetic aspects of the breast. So it's a win-win situation. You get rid of the cancer, at the same time create and restore the breast aesthetic aspects of it.
Fantastic. So Chandra, I'm hoping that the way our discussion will kind of flow, we'll cover a few, I'm going to look at it as elements of the pathway in a way of how people present to you, of how people are more aware of how to identify breast cancer at an early stage, even through screening programs and different technologies that are now available to do that. And then get into a little bit more about what the impact of the diagnosis can be on the individual, how that's managed, and then talk a little bit about, the impacts of the last few years of the pandemic and how that's, impacted on numbers, and then get into treatments and longer term outcomes for people. Yeah. So that's kind of how I'm going to break it down. So I'll start off with just asking you, where do your patients come from in the sense, do they self-present when they feel a lump? Do they come from mammography screening, for example? So why don't we take one of those at a time, and you tell us, how people come to you for an opinion or when it's identified.
So thank you. I think you've answered the question partly yourself. So there are two main streams of inflow of patients to our practice. One is through the screening program, which, as you're aware, is a national screening program. And we'll talk more about that in a minute. And the second inflow is symptomatic clinics. So symptomatic clinics is where patient sees a GP and with breast lump or nipple discharge or breast pain, and they then get referred to a NHS or a private clinic, depending on where the patient wants to go. So this is essentially the two main streams that the patients come through. Then obviously have the family history referral pathway. Patients on the family history clinic can get referred because of having a lump in the breast or symptoms. And then occasionally we also have referrals from a metastatic setting where patients present with fracture of the bones or liver secondaries or lung issues, and then biopsies are done and that picks up breast cancer and then they get referred. But the main stream pathway is essentially screening program, and symptomatic pathways are the main two streams of referrals to our practice.
So in terms of the symptomatic stuff, so one of the things that, women who I see from a general medical perspective, because that's obviously my field, and I'll take menopause as an example. When I'm treating women with HRT, which is something that I do in my specialty, I always recommend that they self-examine.
Absolutely.
And is there any, would you signpost people to any specific, websites or anywhere where there's a good description of how they should self-examine? Is there a technique that they should follow?
Absolutely. The breast awareness is an extremely important aspect of managing breast health, and early detection is the main benefit of breast self-examination, and there are quite a few numerous websites at the moment, like breastcancer.org and breast health, and there's one consultant colleague of mine, I miss her name now, she has produced an excellent video of self-examination, and I'll get back to you on that particular website so we can include this in our talk later on. So self-examination is very important, and I would advise every single patient who walks into my clinic and give them a leaflet as to how to self-examine themselves. And that definitely helps the patient in picking up early presentation.
And you talked about the mammography national screening program. How does that work? I mean, what's the age group that they start with and criteria for that?
Excellent question. So breast screening program in this country starts from 47 and it ends at 73. And after 73, a patient can self-refer. It doesn't stop. It stops. The automatic recall every 3 years stops. But after 73, the patient can self-present requesting a mammogram. So from 47, every 3 years, patients are invited through the central breast screening program through the GP practices. That's how they're picked up actually. And it goes postcode by postcode. And patients between the age of 50, as I said, 47 to 73 are invited for a breast screening mammogram, which is actually a 2U X-rays of the breast. And this can be at static units, where in hospitals or clinics, or it can be mobile units. You have mobile vans in, for example, a supermarket, shopping mall, and patients are invited closer to the home, so you increase the pickup rate of that rather than asking the patient to travel a distance for the mammogram. So once the patient attends for a mammogram and has it, the mammogram is looked at a central location in different screening units, and they're double read. So what it really means is a consultant radiologist would look at the mammogram individually, and they report it individually. So if both conclude the mammogram is normal, the patient is sent out a letter within 2 weeks to say it's all fine. And if both agree there's an abnormality, patient is recalled for further assessment in a screening unit like ours at the Royal Liverpool. But if there is a discrepancy between the two consultants' opinion, then it goes into arbitration of a third radiologist, and that's why it's sorted.
That's fantastic. I mean, it's nice to know that there are so many layers of safety and security and multiple opinions taken, because making a diagnosis or not is life-changing at the end of the day.
Absolutely, yeah.
And in terms of the mammograms themselves, I mean, do you get women who come to you who feel uncomfortable going for mammography, or do you think the uptake is pretty good? I mean, what do you see?
The uptake is variable, and there's always huge public awareness attempts made to increase the pickup rate of mammogram. There's anxiety associated with that, taboo associated in certain racial group, particularly in the Asian group. The pickup rate is slightly lower because of the taboo that is associated with that. And there's again anxieties around health and concerns. But generally the pickup rate is consistently in the upper 70s to 80s. So that's where we are at the moment. Yeah.
Excellent, fantastic. Yeah. I wonder if I could pick up another topic that you touched upon, which was the family history clinic.
Yeah.
And the family history clinic is an interesting concept. And one of the things that I get asked quite a lot is, people come to me and say, my grandmother had breast cancer, but that's all I know. I don't know anybody else. So I often get asked, well, what's the criteria to get into the family history clinic? Is it one first degree relative? That means, separation by 1 degree, which means father, well, not obviously father, but mother and sister, or is it a once removed second-degree relative. What's the criteria and how does that system work?
Yeah, very good question. So first of all, let's try and understand what first-degree relative means and what a second-degree relative means. First-degree relative is relatives like mother, daughter, and sister. So these are relatives with whom you share maximum genes, okay? And then anybody else becomes secondary relatives. So the criteria for referring a patient to a family history clinic would be, for the GP, would be if there is a relative, a first-degree relative under the age of 40, diagnosed with breast cancer, that would necessitate a referral to a family history clinic. Then if the patient has got a family member with bilateral breast cancer, or a cancer of the breast and cancer of the ovary, that will constitute a referral indication. And then if you have got 3 members in the family at any age, that again is 3 to 4 members in the family with breast cancer history. It doesn't have to be a first relative. If your patient says, look, I've got an aunt had breast cancer on the dad's side, and the mum side, I've got 2 cousins who have got breast cancer. So if there is a cluster of family history, that itself sort of should should ring alarm bells to say, well, there's something going on here. Let's get this looked at in a family history clinic.
Fantastic. And I've heard that from a family history clinic point of view, there are 2 kind of options that they use.
Yeah.
One is testing genetically in the family, and the second is mammograms at an earlier stage, I think.
Yeah.
So what are the kind of, what would someone with a family history expect to happen to them?
Very good question. So what happens once the patient gets into a family history clinic? There's a family history specialist nurse who usually runs this service. And the patient family history is very carefully looked at, and then they would score the family history of risk based on their family history, like how many members in the family, whether it's dad's side, mother's side, the age at which the diagnosis was made. And based on this, if you hit a certain score, you're first of all categorized as a moderate risk and a high risk. If you're moderate risk, you get offered a screening mammogram in the appropriate age group, and if you're plus 40, you would get that. But if you're younger group, you might be offered MRI. But it's as far as the genetic testing that you are asking about, for that you have to hit a certain threshold, and then you need to be in the strong family history group, like I just said. If you've got a relative who has got breast cancer at the age of 40, or a relative who has had bilateral breast cancer, breast or ovarian cancer, and if you have got 3 members in the family under the age of 60 on the same side of the family, all this would imply there is a faulty gene somewhere, and the only way you can find out the faulty gene is by having a gene test.
And I think, thank you, that's really clear and helpful, because, that's a lot of the stuff that people want to know when they're thinking about these things. There is also a move, and I know that I myself encourage some of my patients who may not meet that threshold to sometimes go and get a private breast cancer gene test done. And I think it helps them to some extent. I don't know how helpful that is or not. I get mixed views. And what are your thoughts on that?
My advice would be to go through a specialist breast clinic personally. There are quite a few private genetic team who are offering this gene test. It's not just about the test, it's about the counseling of it, and then the interpretation of the result. Those are important, and how do you act on that? So my advice would be to go get a referral into a family history clinic and to see a specialist who does family history, geneticist, a surgeon like I do the family history genetic clinic service at Liverpool. So that's important to go through a specialist service rather than just going for a gene test privately, because it's important to understand the test and the counseling that goes with it.
And let's talk about that counseling. I think that's you're really on the ball with that, because I think when people go and do a test, if you're not prepared for the outcome of the test, it leaves you with anxiety.
Yes.
It leaves you with lack of direction in terms of what you should be doing. And so let's assume that you do volunteer to go and get one of these tests through a testing service that has got the support structure behind it. what are the options? Let's say it comes back positive. What are the kind of options that women have if you come back breast cancer gene positive? BRCA, it's called BRCA1,
Yes,
BRCA2.
that's right,
correct me if I'm wrong, but what do people get offered if they turn out positive?
So let's see what BRCA stands for. So BRCA is BRCA. The BR stands for breast, and the CA stands for cancer. So it's breast cancer gene. That's what BRCA stands for. And there is BRCA1, 2, and there's several other, but the of interest is BRCA1 and 2. So before I go on to talk about the positive, let's look at the outcome of a test and how to interpret that. The three outcomes really. Number one, the test may come back as the particular patient is BRCA1 or BRCA2 positive. And then it may be negative. And the third option is inconclusive. Sometimes you get this result saying inconclusive, which means they have not found the fault, but that doesn't mean that it's not there. So let's look at what positive means. So when positive means basically BRCA genes are what are called tumor suppressor genes. So all of us have got BRCA gene in us. And this particular gene would control cell growth. And when there is a fault in this, cells multiply uncontrollably, and that's how you develop cancer. So it is the mutation. If there's a mutation, that's a change in this BRCA gene, that capacity of this gene to control cell growth is what is going to cause what is going to cause cancer. So in BRCA1, if a patient is positive, there's increased risk of breast cancer and ovarian cancer, whereas in BRCA2, it's just breast cancer. So generally, when people have BRCA1 gene positive, the recommendation would be to offer them both mastectomy and oophorectomy in a risk-reducing protocol.
So that means both breasts removed and both ovaries removed?
Yeah, it depends on the age and where they are in their family. For example, if somebody is very young, you won't be offering that. They obviously want to consider having their family done. So if you do an oophorectomy, they obviously can't have family. So this is a broad advice, but each patient is individual, and it has to be managed according to their individual needs.
Yeah. You can see that being quite a challenging decision to be made, can't you? Especially if you're young and you have the test and it's positive, and then you're thinking about, I haven't started my family yet. Do I get on and do it? What do I do? And, it must be quite a emotionally charged kind of...
Yeah. Again, surgery is not the only option. Okay. Surgery is an option that you wish to consider, and surgery offers a significant reduction in developing cancer. The alternatives are the patient can go on chemoprevention drugs such as tamoxifen, or they can just be on surveillance. So this is a very long process. This needs a detailed counseling. It's not something that should be rushed at all, because patients would regret this. And therefore, in my practice, it's deliberately slow. And from the time of diagnosis, by the time they have surgery, it'll be at least a year. So there's sufficient time is given to the patient to make sure they understand the implication of risk-reducing surgery, which is it's irreversible. You can't reverse it, and it's sort of permanent, and it's life-changing. So these are very important, and therefore patient has to be counseled accordingly, given all the options of surgery, surveillance with mammogram, and MRI in the appropriate age groups here.
And I guess, through this discussion around surveillance, early self-diagnosis, mammography, genetic testing, all of these modalities, I know that we're probably picking up more people sooner, which is a good thing.
Yeah.
And do you think that is part of the reason why that we're seeing better outcomes for people with breast cancer when you pick it up, because you pick it up early?
Absolutely. Spot on, isn't it? The more you're aware, and the more you are aware, you seek help early. Early diagnosis means the cancer has been caught early. Treatments work very well, and the outcome improves. It's always good. It works good for the patients. It's good for the health services, because you manage cancer early, and so that it's a win-win situation.
Fantastic. I'm going to now move on to the next kind of stage in my head of how that journey looks for the woman. And let's say that through one of these modalities or through symptomatic presentation, a woman comes to your clinic. what does that then start in terms of a treatment journey for that for that patient? The conversation, obviously it will be an emotional time. What are the support structures that are there for giving a woman that support at that point when they haven't yet come to terms with the fact that they've got this and need to slowly start thinking about? Because I know when I give bad news that some of the detail around what I want to do for them doesn't stay. It doesn't stick. And one of the things we find, I'm sure you see this all the time, is we need to give women in this scenario the kind of psychological support, the kind of support that they need to come to terms, the emotional well-being support. Are there any services that are around that help them with that?
Right, so let me understand this. You're talking now of a patient who's been diagnosed fresh with breast cancer.
Yep.
Yeah, it's very, very important that they are supported adequately, because it's a life-changing and a very scary diagnosis for them to hear. So in most units in this country, there's a breast cancer nurse support. And every time I give a diagnosis, I always have my nurse with me, and she would spend time with the patients after my discussion and give the patient relevant supporting information, contact details, and support. In the private setup too, we do have breast care nurse support. At least in most well-established private clinics, that support is provided. And then, of course, you have this non-NGOs or the NGO setups in most cities who look after patients. And this is basically comradeship, where people who have had breast cancer in the past and have gone through that are there to support. They can visit their local, if you just Google for your local breast cancer support societies, it'll come up, and then all it needs is one phone call. They're very, very supportive group, actually. They're very much into it. And then, of course, you have got the Macmillan support group. They're always there for patients to pick up the phone and talk to somebody and to give advice.
Fantastic. And then what's the first kind of conversation? There's so many treatment modalities that, or when I say modalities, let me make that treatment options.
Yes.
There's surgery, chemo, radio, things that we hear and we talk of in the medical sphere as, day to day. But talk us through some of those things that you would do as a surgeon, as a treating consultant for these women, so that people understand what that entails.
Yeah. Well, I think the first thing to say is any new cancer diagnosis or any cancer diagnosis has to be discussed at a multidisciplinary meeting. And the surgeon, the clinician would go to the meeting with all the information, the diagnostic information we have, such as size of the cancer, obviously the age of the patient, fitness of the patient, and then the size of the cancer, grade of the cancer, is it hormone sensitive or not, and so on and so forth. Has it spread to lymph nodes or not? Based on this information, you then plan treatment. In majority of the patient, if the tumor is small and has not spread to lymph nodes, one would offer surgery in the form of a lumpectomy. And although the word lumpectomy is loosely used, the correct word is wide local excision of the cancer. And if the cancer is bigger, larger, and then obviously we would be looking at options of giving them chemotherapy upfront to make it smaller. And then obviously the aim would be to sort of try and do breast conservation surgery, that is to save the breast. There's a big emphasis on de-escalation of surgical treatment now. We have gone full circle from starting with lumpectomy to mastectomy to radical mastectomy, and we've come all the way back to breast conservation is as good as mastectomy. And a recent publication has shown that breast conservation surgery appears to be better than mastectomy if you can avoid mastectomy. So we've come a full circle, and breast cancer, as you rightly said, is treated by multimodality treatment. So there's multiple things that goes on to treat patients. Surgery is still the mainstay, and this is usually followed by chemotherapy in the appropriate setting, and I'll talk about this in a bit. Then we have got endocrine therapy. Breast cancer is one of those cancers in the body which responds to hormone manipulations. We'll talk about that. And then we have radiotherapy. And then nowadays we have this biological therapies called monoclonal antibodies. That's a big thing. If there's anything that has changed breast cancer outcome in the last decade, it's this monoclonal antibodies called trastuzumab, and the family of drugs have done a huge difference, positive difference to the outcome for the patients.
So that's interesting that, we used to always think that when surgery was the option, yes, I understand the concept of lumpectomy, where if it's a small lump, you try and just take the lump out. And mastectomy was essentially you take all the breast tissue on that side out.
Correct.
And I think the other term you used was radical mastectomy.
Yeah.
And I think that means you go further and it's the lymph nodes, I think, that you
radical
take out.
mastectomy was taking the lymph nodes is part of their mastectomy to stage the armpit nodes. Radical mastectomy is where the breast was removed along with the underlying pectoral muscles in a radical way. At that time when this was being done, they thought more was good. Bigger operation meaning getting rid of everything. And that thinking has now changed radically. We now realize that it's not necessary. And because breast cancer is not just surgery. Breast cancer is a truly multidisciplinary management. So chemotherapy, endocrine therapy, radiotherapy, all these are additive and they enhance the patient's survival.
That's great. And I think with the chemotherapy side, just in simplistic terms for me, are the options kind of intravenous? Are they tablets, or is it a mixture of those? Without going into the detail, obviously you're the surgeon, and I'm sure you know about the oncology side, but I won't put you on the spot with that.
No. So first of all, let's see in whom we would recommend chemotherapy. This is just broad strokes. This is not specific to every patient. Every patient will have a tailored, individualized treatment plan given by the respective consultant and their multidisciplinary team. But generally, for patients in whom we would recommend chemotherapy are patients who have got grade 3 cancers, patients who have got large nodes, patients who have got lymph nodes positive disease, that is evidence of disease, metastatic spread to the lymph nodes, and then patients who have got what we call hormone negative cancer, that is estrogen and progesterone receptor negative cancers would require chemotherapy.
So by grade 3, that's like a more, is that under a microscope?
That's correct.
It looks more aggressive.
That is correct.
So the more aggressive you give
chemotherapy.
And then the lymph nodes is the glands
in the armpit, to which the breast cancer cell can spread. That will be the first port of spread for the breast cancer cells.
The other scenario that you mentioned where you would use chemotherapy is where people are hormone receptor negative.
That's correct.
Right?
That's correct.
So that goes back to, and this is as an endocrinologist, I kind of get this, is that some cancer cells, breast cancer cells, have got receptors on the surface which estrogen, which is the female hormone, and progesterone, which is the other female hormone, can go, and if those receptors are there, it can drive the cancer.
Correct.
But if you don't have those, then you've got to use what we would consider traditional chemotherapy.
That's correct.
Because you can't hormonally manipulate the growth.
That's correct. Yes.
Right? So that's the third scenario, isn't it?
Yeah. So let's a few words about this hormone receptors. So the facts are, if you take 100 breast cancer patients, 60 to 70% have these receptors on the cell surface for estrogen and progesterone hormones, okay? And the best way to understand this is if you have a breast cancer cell, the receptors are like keyholes, okay? And estrogen and progesterone are like the key. So if the cancer cell has got estrogen receptor on its surface, estrogen hormone is the key that will stimulate growth, and that's how it works. So in these patients, we would use drugs that either reduce the production of estrogen or acts as a dummy key, like tamoxifen is a dummy key. What it does is blocks off the estrogen receptor on the cell surface so the estrogen cannot work and stimulate cell growth. That's how it works.
Perfect. And is that part of the reason why you would kind of do ovary removal, so oophorectomy, or is that different?
No, we won't be doing oophorectomy at all these days, not for breast cancer treatment, because there are drugs which does the job. If you want to sort of suppress the ovarian function in a premenopausal women only. We use drugs such as goserelin is used.
So that's the injection that you give every 6 or 3...
4 weeks.
Every 4 weeks.
Every 4 weeks. It comes as Zoladex.
And that kind of stops the estrogen production.
From the ovary.
From the ovary.
It makes the woman postmenopausal.
Right. And therefore the cancer, which has got the receptors, can't grow.
Correct.
And you kind of retard it and slow it down and stop it from growing.
That's right.
Excellent.
That's how it works.
And then you talked about this fascinating new group of medications called monoclonal antibodies. We all know what antibodies are now after the pandemic. It's supposed to be things that fight external forces. But these antibodies, just like you've described, what you're using them for is kind of fighting the cancer cells in a way?
Yeah. So the story with this is, these are called HER receptors. They stand for human epidermal growth factor receptors. It's a mouthful to say, but all you have to remember is HER receptors. Essentially, there are 4 of these, HER 1, 2, 3, and 4. But of relevance to the breast cancer is HER2 or HER2 receptors. This is exactly like the estrogen receptors and progesterone receptors, which is a keyhole on the cell surface, and the epidermal growth factors will stimulate them to grow, and the cancer cell grows. These monoclonal antibodies, which are called trastuzumab, they are the key that goes and blocks this, and therefore the cell cannot multiply or does not respond to your growth factors, and that's how the cell sort of dies. And if there's one thing that has changed the outcome in breast cancer survival, it's been this discovery of trastuzumab drug. And sold as Herceptin.
I was just going to say that. That's where the name Herceptin comes from.
Intercept the HER2 receptor.
And I think it must have been about 8, 9, 10 years ago, maybe longer, that Herceptin, there was a big hurrah around people getting Herceptin, but now it's more available. I think before that it used to be difficult.
Well, it still costs about 20 to 30,000 pounds per patient treatment, and therefore when it started off, there's a big hoo-ha about who should get this, who shouldn't get this. And I'm glad to say that on the NHS, anybody who is HER2 positive and in the appropriate indication, they would receive this treatment in this country.
Fantastic.
Yeah.
And the other concept that has developed over time is this thing about precision medicine, and this is what we're talking about,
precision.
Isn't it?
This is tailoring individual. This is targeted therapy. That is, instead of giving it like chemotherapy, for example, it used to be a blanket treatment. Everybody who was great, was being given chemotherapy, but now we target an individualized patient care, and this is where the Herceptin comes in. And to talk more about, you're going to talk more about this precision treatment.
I was just going to ask about, so there's a concept that I keep hearing about next generation sequencing or NGS, where they take the sample of the cancer tissue, run genetic and receptor testing on it, and that's what allows you to kind of decide which chemo, which hormone modification, and do things like that.
Yes, spot on this actually. This particular gene sequencing is now called Oncotype DX testing. This is basically a test which looks at 21 gene assay, right? And what this does is it looks at, in the past what used to happen was patients who were deemed high risk, like the grade 3 cancers, node positive cancers, they were all given chemotherapy. Now we understand that not all of them need chemotherapy, and they're having chemotherapy with no significant benefit, but they're subjected to significant toxicity of chemotherapy. So this Oncotype DX test, which is done by Genomic Health, looks at this 21 gene assay, and then you get a score. Now 0 to 100 is the score, 0 minimum, maximum of 100. And if the score is 25 and less than 25, you're not going to benefit from chemotherapy. If the score is between 25 and 100, we would recommend chemotherapy. So in the past, we would have given chemotherapy to everybody in this group, but now we are targeting and identifying patients who will specifically benefit from chemotherapy. And this is what the gene testing is doing at the moment.
Excellent. And then the other part of this is, I know some patients who come to me tell me about having drips and infusions of a medication called zoledronic acid or zoledronate. And that, in my world, that's used for treatment of osteoporosis.
Correct.
But actually it has been shown to have additional benefit in breast cancer as well.
Absolutely. That's you're spot on there. Now that's another additional treatment that we have for patients who are postmenopausal and ER receptor positive, that is estrogen receptor positive patients. And this zoledronic acid injections is given every 6 months for 3 years. And what studies have shown, a study of 7,000 patients showed was, by giving this zoledronic acid, it increases overall survival by 14%. Okay, what it means is, if 100 patients were going to live without zoledronic acid, if you give zoledronic acid, 114 people are alive with disease-free. So that's overall survival, by the way. So in addition to that benefit, by giving zoledronic acid, you can also reduce the risk of distant bone metastasis by 19%. And the third important thing is, by giving zoledronate or zoledronic acid, you reduce fracture by 25%. So it's benefit all around.
Fantastic.
Improve overall survival, reduce bone metastases, and reduce fractures.
And you know, this has been a fascinating conversation because we've been able to cover a whole array of things. I think the only thing that is left out of that, if I remember correctly, is radiotherapy, and there is a role for radiotherapy.
Of course.
And how does that fit into all of this?
So when this treatment for breast cancer was evolving, we just did lumpectomies, and then in a proportion of patients, the breast cancer would come back. And then by adding radiotherapy, it became evident that by giving radiotherapy, you reduce the risk of disease coming back in the breast by 35%. So at the moment, if you have wide local excision and radiotherapy, your risk of developing disease is less than 3% in the breast. Okay, that's what radiotherapy has done. But radiotherapy has changed a lot over the years. In the past, it used to be 25 days treatment session, and then it reduced to 15 session, and now recently it's just 5 days. It's called fast forward treatment, so it's just 5 days. And then we have now come to a stage where the talk is of de-escalating treatment and targeting and giving treatment who needs it rather than everybody gets it. So patients who have got extremely good outcome tumors, like a very small tumor, grade 1 tubular cancers, and in patients who are 16 plus, they don't need radiotherapy. We can get away without that. And the other newer development is what is called partial breast radiotherapy, where you would actually give radiotherapy only to the tumor bed area and not the whole breast. Again, this is for a specific good outcome cancers, and the patient should consult their specialist, and they will guide them as to what would be best for them.
So it's great to know that so much development has gone on, and that is why we, at least from the data I've seen, people are surviving.
Absolutely.
In remission, as we use the term, which means cancer-free.
Yes.
At what point? So let's talk about how long you follow them up for after you think that you have gotten rid of all the cancer. What's the sequence of events and duration?
Again, good question, but this varies from unit to unit, and each unit has its own policy. And what I tend to do is, for most patients who have got good outcome cancers, I would see them for 1 or 2 years, and then I would arrange mammograms for 5 years, annual mammograms, and then if the patient is in the 50 plus group, they would actually get discharged to their breast screening program. So after 5 years of yearly mammogram, they rejoin the screening program and get mammogram every 3 years. For those patients who are younger than 50, they would carry on having 5 mammogram until they're 50, and then they go on to the screening program. This is general follow-up for patients who have got early breast cancer. But then patients who have received chemotherapy, some chemotherapy have cardiotoxicity, that is, can affect their heart, and these patients are monitored for a long time. Again, a radiotherapist might want to follow up the patients for toxicity around radiotherapy, and they might want to see them for years. And then again, patients who are on clinical trials get followed up based on the clinical trial protocol. But generally, the follow-up is short, but then they get the surveillance mammographic follow-up for those patients. Yeah.
And the kind of duration of 5 years is kind of quoted for kind of after 5 years, and I think that's to do with the duration they're on these hormone medications, isn't it?
Yeah. So that's a good point again. So the big question is, how long should be the adjuvant endocrine therapy? So generally, we would be advising 5 years of therapy for most patients. But patients who have got very good prognosis, very small cancers, grade 1s, 5 years is good enough. But anything more than that, the current thinking is to extend for 10 years.
Okay.
So what we have noticed is by extending the treatment from 5 to 10 years with endocrine therapy, you enhance the disease-free survival from 28% to 49%. What it really means is you're reducing the distant recurrence from 9.5 to 7%, which means if patients took treatment for 5 years, at 10 years, 9.5 would relapse. But if they carry on taking 10 years, that 9.5% will drop to 7%. So there's an absolute benefit of 2.5%. So it's definitely one of the problem. The positive is you reduce risk of relapse, but the problem with long-term therapy is osteoporosis, and so therefore these patients has to be monitored. And my recommendation is to have a bone mineral density scan, what is called DEXA scan, every 18 months to 2 years to make sure the bones are not thinning out. And all these patients who go on the endocrine therapy, particularly what we call the aromatase inhibitors, which can cause bone loss, they should have calcium and vitamin D supplements and closely monitoring their bone health.
Let's talk about also kind of the, post-treatment effects. So, you do see a lot of women who worry about hair loss, going through the menopause, stuff like that. I mean, what's the support structure there and what's the advice on that?
Obviously, some of the medication, chemotherapy obviously causes hair loss, but chemotherapy-induced alopecia is temporary. All these patients will get their hair back. But then a certain aromatase inhibitor, the endocrine therapy, can be associated with hair loss. And the simple solution to them is to change it to an alternative form of aromatase inhibitor. But I would always advise my patients to stick with endocrine therapy because the benefit is so substantial. And hair loss is an important aspect to the patient, and that can be managed by changing the medication or assistance from hair hair replacement, and like wig and whatever can be used.
Well. I think it's been fascinating to hear your expertise. You obviously you walk the journey with your patients. You know exactly how they feel. You understand it, and your wealth of knowledge comes across tremendously. And I'm hoping that we've been able to put that in simplistic terms for people who are listening and watching us today. I think for me, one of the things that you said early on is probably the important message that I want people to take home. Both of us come from an ethnic minority background.
Absolutely.
And that taboo that you talked about, where people don't want to, it's almost like bury your head in the sand and it'll go away. It doesn't go away.
No, it doesn't.
And hopefully, people listening and watching now know that we can provide treatments through the likes of yourself, your teams, colleagues around the country and around the world, where we can cure this. We can beat breast cancer.
Of course.
We can help people live meaningful, long lives. But the important thing is coming forward and dealing with it.
Absolutely.
And using the technologies for screening, the genetics that's available, and just being breast aware, which is a big concept.
Absolutely.
That's kind of the final thought from me. You're the expert, and I'm going to leave the final word for you on the topic. If there's anything else that you think our viewership should know.
All I would say is breast cancer is quite common, but the treatment is excellent. The outcomes are getting better and better. And the key thing is to be breast aware. So learn how to examine yourself, and examine yourself once a month, not every 2 minutes. That will just lead to unnecessary anxiety. And if you learn the correct way of examining yourself once a month, and if you pick up anything like lump, nipple discharge, thickening, anything different, see your GP and get referred to your local breast clinic.
With that, I'm going to say thank you very much, Chandra. That's Mr. Mysore Chandrashekar, Consultant Oncoplastic Surgeon, who has given us a wealth of information and knowledge today. Thank you, Chandra, and thank you, everybody.
Thank you for inviting me today. Thank you.